Hi guys, this is Charles and I'm one of the surgeons at Southpaws. Today I am doing our Zoom rounds, and I'm sorry I didn't announce it previously. I didn't know what time I was going to be able to get started. So anyway, this is going to be in the standard format, which is where I go through videos that we have on our YouTube channel, our most popular videos, and then I go into detail about the decision-making processes and things like that with each of the procedures. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you get a ding on your phone the next time we live stream, and also have a look at our YouTube membership. Our YouTube membership is a way for our YouTube community to support us a little bit and to help pay for camera equipment, digital marketing, and that kind of thing. It costs about $22 a month US. And you can cancel anytime you'd like. So the first case that I'd like to talk to you about is a toe amputation in a dog. And so what we have here is we've got a mass on the lateral digit of a dog. Now, when we think about digital masses, let's see here. So nail bed tumors in dogs, there are a couple of them. So we often see soft tissue sarcomas or mast cell tumors, that kind of thing. And those are going to behave the same as they are in any other location. But there are a couple of them that behave more aggressively in the nail bed location than they would in other locations. So those would be melanoma and squamous cell carcinoma. So with either one of these, so normally you think of, for example, melanomas in the skin. Melanomas in the skin are usually quite benign, whereas, hold on just a second, whereas with melanomas in the nail bed, they can actually have a fairly high metastatic rate. And we will often think about treating these dogs with chemotherapy. And usually when you're going to do chemotherapy for a melanoma, we are going to look at carboplatin chemotherapy. And the other thing that we're going to want to do is we're going to want to look at regional lymph nodes. So we're going to aspirate regional lymph nodes to see if there's evidence of metastasis. And we're also going to take thoracic radiographs. If you had a cutaneous melanoma somewhere else, like on the lateral chest wall or something like that, you wouldn't have to do thoracic radiographs or aspirate regional lymph nodes because they are quite benign. Same thing with squamous cell carcinoma. So when you think about a cutaneous squamous cell carcinoma, particularly one that's solar induced, we're not going to be too worried about metastasis, but when they occur in the navel bed, we are going to be concerned about metastasis, and so we are going to think about doing regional lymph node aspirates as well as thoracic radiographs. So coming back to our video here, I personally like to put a tourniquet on these, and I'm not sure if I do in this video, but I think that I will. Now, whenever you have a nail bed or a nail that falls off spontaneously all the way up to the nail bed, and then there's swelling of that P3, you need to at least consider the possibility that it has a nail bed tumor. Nails spontaneously don't fall off that often, especially without any trauma. And so, again, you have to consider the possibility that there's a nail bed tumor. So I like to put a tourniquet on these guys. And let me just see if I can advance this a little bit forward. So what I'm doing is I'm putting on an Esmark tourniquet. And the way that works is that you use vet wrap. You put it quite tightly around the foot, and then you just give it a twist about 180 to 360 degrees on every couple of laps. And what that does is it creates a really nice tourniquet function or tourniquet action, and that will help prevent or reduce bleeding from the amputation when you do it. Now, you want to make sure, number one, that you don't keep the tourniquet on for more than about 20 minutes. And number two, when you remove that tourniquet, it is going to start bleeding. So then you want to address all those interdigital vessels with ligation or electrocautery. Now, the other thing with nail bed or with amputations is that I typically do not cut through the bone. I'm more likely to disarticulate at the metacarpophalangeal junction. So rarely do I go to P1, P2. Usually I'm going to go all the way up to the metacarpal phalangeal junction, and I'm going to disarticulate. You don't need to cut the bone. There's no problem with leaving synovial lining in there. You're not going to have continued production of synovial fluid, and if you do, it doesn't seem to cause any problem. So now I've cut in the web, and I'm just going through and I'm cauterizing vessels as I see them, recognizing that even though you cauterize it down to basically a dry surgical field, when you remove the tourniquet, it's going to start bleeding again, and you want it to, because you don't want it to start bleeding the next day. And there's a comment, I use this technique and that I learned in one of your previous videos, and it works so well. So thank you very much for making that comment, Emily, and note that these do work quite well. Now I'm just pointing out here, so I'm going all the way up to that metacarpal phalangeal junction. Can't remember if this is a hind limb, so it's going to be the metatarsal phalangeal junction. The behavior of nail bed tumors does not vary depending on whether it's front leg or back leg. It doesn't make any difference. Anyway, so I'm going to make this elliptical incision all the way up around and up to the metacarpal phalangeal joint, cauterizing along the way. We're just going to transect all the flexor and extensor tendons and disarticulate, and then we're just going to close in 2 or 3 layers. Again, you can leave that tourniquet on for about 20 minutes. My digital amputations always take me exactly 12 minutes. I don't know why that is. The ligature is really nice to ligate those interdigital vessels, but certainly is not absolutely necessary. And I've done hundreds of toe amputations before I ever had a ligature. So now I'm going to cauterize through the extensor tendons here and expose that articulation. You can block these. You can do a nerve block using mepivacaine. Usually what we end up doing is just injecting mepivacaine into the surgical field. So so I've just disarticulated that joint right there, and you can see the distal end of the metatarsal bone right there. And so no problem with leaving that distal metatarsal bone intact. All right, so now I've cut that. I'm going to have a good look at the vessels, anything that's obvious there, and then you're going to see when I remove that tourniquet, it's going to start bleeding again. So I'm taking that tourniquet off now, and then you'll see that it starts bleeding again. And then we're just going to go back in and cauterize those individual vessels. All right. Are there any questions about the toe amputation? I'll show you a little bit about the closure. For the bigger bleeders, we will use hemostats. Just advancing a little bit further. So doing a deep sub-Q layer. Now the procedure is the same if you're doing, so this is the lateral digit, so it makes it easy. But if you were doing one of the middle digits, you do it the same way. You'd just be suturing the web from each of the adjacent digits together. Any questions about that? All clear? All right, so I'm going to go ahead and wrap that one up. And let's see what our next one is. I've already done many total ear canal ablations, so I won't do that. I will do a abdominal exploratory, and that's a 5-minute video, so I'll just keep that running. So I'm off center here a little bit. Oh no, this one isn't a good one. This is when I was using a headset. And so you're going to get very dizzy. Let's look at a brachycephalic airway syndrome. So brachycephalic airway disease is very, very common and getting more common. So what I've done here is I've already done a tonsillectomy. Let's go back to the beginning. All right, so we've got our stenotic nares here. And this is typical appearance of stenotic nares in a brachycephalic dog. Now, what I do now, I'm not sure if I do it in this video, but what I usually do now is I'll inject some lignocaine and adrenaline, or lidocaine and adrenaline, into the nasal planum. And I use a mixture 50-50, and I use about 1 mil per nostril of a mixture of the two. I don't think I've done it in this case, but that's what I do now. So about, sorry, 0.5 mil of a mixture in each side. Now, then what I do is I put in a stay suture using 4-0 PDS. And then with that stay suture, I'm going to have an assistant retract that dorsally. And by retracting that dorsally, it's going to allow me to get a really nice wedge of tissue. Now, I'm just going to stop for a minute and go back into our drawing here. So when you look at the nose like this, and this is the nasal, the nostril right here, what I do is I get a PDS suture and retract dorsally. And what that allows me to do is it allows me to take a much larger and deeper wedge. And so I'm going to take the wedge out here. But then when you retract that dorsally, what you see is that the suture is up here, and then the nostril is kind of being pulled up like this. And so then when I take my wedge, I can take it like this, but I'm also going to go really deep into the nostril with my wedge. And so it's going to look almost like a diamond when you pull it out. And then once I pull that out, then I'll be able to just close that with a simple continuous. And you want to take fairly large bites with your simple continuous, otherwise you can get dehiscence of the wedge, and it will eventually scar back down and it won't be a problem, but it looks ugly for a couple of weeks if it does dehiss. So we'll come back into our all right, so now I'm pulling dorsally with my stay suture, and this is one that I have not done the adrenaline and lignocaine, and so you are going to see some bleeding here. But I've significantly reduced my bleeding by using the adrenaline and lignocaine. Having trouble getting a grip on the nostril with these thumb forceps, but you can see that I'm going quite deep into that nostril with my cut. Then I'll cut the other side and get that nice big diamond shape piece of tissue. And the key with these, again, is to go quite deep, because it's not just stenotic right at the opening, it's actually stenotic going quite deeply into the nostril. All right, and then when we pull that up, by pulling up dorsally, I'm also going to be able to get my sutures quite a bit deeper into the nostril as well. Okay, any questions about that? So I'll go a little bit more quickly and we'll get on to the other nostril. So I'm doing the same thing there. Put in that stay suture. And that stay suture is something I recently discovered probably about 4 years ago. And it makes such a difference in your ability to get a nice big piece of tissue out. I probably have some better videos since I started doing the adrenaline. I don't get anywhere near this much bleeding. And I'm also able to visualize better and then make my cut deeper. But these do bleed quite a bit if you don't use adrenaline. So see how we're using that stay suture to retract dorsally, taking some nice big bites through the tissue there. And again, just a simple continuous suture pattern. And that retraction also, I don't know if I said this before, makes it bleed less as well because it puts the tissue under a bit of tension. Okay, any questions about that? All right, so we'll move on to, you can see what it looks like when I'm finished. So that looks pretty good, nice and open nares. All right, so then heading over into our airway. It's always hard to video these. So when I do staphylectomies or soft palates, I've got three different choices. One is just to put in stay sutures and then cut with scissors. And I'll draw you what that looks like. So let's say you're looking at the back of the throat here. And let's say you want to remove this much of the soft palate. Basically, what we want to do is remove even with about halfway or even 3/4 of the way up the tonsillar crypts. And so what I'm going to do is I'm going to put in, there are a couple of ways you can do it, but one way is to put in stay sutures here, here, and here. And then you start cutting through here, and we're going to retract that soft palate this way. So then you have to make sure. So once you've started retracting this out of the way, kind of like this, so you've pulled that out, and you're going to be looking at oropharynx and nasopharynx. So you want to make sure that we're suturing the mucosa on both the oropharynx and the nasopharynx, like that. Is that clear to everybody? There's a question about cauterization. I don't know if that's on the nares. You definitely never want to use cautery on the nares. We've seen some really severe strictures form, and you can use electrocautery on the soft palate. So then you kind of go halfway across, and then we're going to cut the rest of the way across, which means that then we're going to have a gap here. So you're going to be pulling down on your soft palate there, looking at the oropharynx and the nasopharynx here, and you just keep cutting along until you have basically cut it completely off. And then just close it all the way up like that. So that's one good way that you can do it. Another way is to, if you're lucky enough to have a ligature, is what I'll do is so if this is the margin of the soft palate, I'll just grab on to the soft palate using a Satinsky, if you have one available, and just pinch off exactly how much you want to take off. So this is our Satinsky forcip here. Pinch off how much you want to take off, and then I'll just take my ligature and I'll just ligature across like this. And it's much, much quicker. You do have a bit of necrosis that can develop with the ligature, especially if you go back and look at these a week later, but clinically we don't see a problem. And so how do you know how much to excise? So again, I usually go about halfway up the tonsillar crypt, and we might be able to see it on the video here. So let's go back to our video now. And I honestly can't remember how I did this soft palate resection in this particular dog, whether I use suturing or ligature, and we'll find out in just a minute. So you're just going to want to make sure that you go all the way back caudally, as far back as you can go on that soft palate, because that tip is what's going to be sticking down into the larynx. And then we're either going to grab onto the tip with a stay suture, or I'm going to use a Satinsky. You can also just ligature straight across, but we'll see what I did in this one. I can't remember. It's been a long time since I did this video. And then the alternative is a folded flat palatoplasty. So let's move ahead and find out which one of these. Okay, so this one, I think I used possibly coblation for a folded flat palatoplasty, but let's see. You can do the folded flat the same way as you do with coblation, same way as you do with scissors. So basically, I'm just using that coblation to pull partial thickness away from that thickened soft palate. And the way that I decide between using coblation versus using just a staphylectomy. Deciding whether I'm going to use a folded flat palatoplasty versus using a staphylectomy depends on the thickness of the soft palate. If the soft palate's just long but not thick, I'll just excise it. Whereas if it's really thick, like in an English bulldog or something like that, I'll go ahead and do a folded flat palatoplasty. So I'm just going to pause this and show you what we mean by folded flat palatoplasty. So we'll go on to another page here. So let's say these are our tonsils here, and this is our margin of soft palate like this. What we do with a folded flap, if you did a sagittal section of a dog's nose, you have the hard palate here, and then you have the soft palate like this, and then the larynx down here. So what we're doing with a folded flap is that we're taking out about half or more of the thickness of the soft palate and throwing that away. And then once that's gone, so now it's half thickness. And then what we're going to do is we're going to pull this part up to here. So when we pull that up, it's going to look like this. So we've taken out partial thickness, and then we're going to take this margin pull it up like this. So it's all the way up here. And now our soft palate margin is down there. And then we're just going to use a couple of stitches to start with. And then you can either do the whole thing in simple continuous, or you can do it in a simple interrupted suture pattern. Now there's a question, have you ever had a problem associated with growth of scar tissue and recurrence? I have had recurrence of brachycephalic airway syndrome. I don't think it's scar tissue. I think it's just progressive swelling of the soft palate. So let's go back in here. I'm using coblation here, but again, you could use just Metzenbaum scissors or cautery or whatever. And we're just removing a partial thickness of that soft palate. I'd forgotten that I had a coblation video of folded flat palatoplasty. And coblation works by creating a plasma gas field that just vaporizes the tissue. And it's been shown to cause less swelling than electrocautery with humans having tonsillectomy. And yeah, less pain. Temperature only gets up to about 50 degrees Celsius instead of 450 degrees Celsius that you get with cautery or ligature. So see how I'm taking that partial thickness away of the soft palate. And then we'll move this along a little bit further. And I'm sorry that it's so out of focus. It is a hard area to video. So then I'm starting to take, let me just go back a little bit and see if I can tell where I started doing that suturing. Okay, so I'm suturing in the middle there. The nasopharyngeal mucosa to the oropharyngeal mucosa. Is that clear to everybody what I'm doing there? Just shout out if it's not clear. And then I'm just running a simple continuous suture pattern all the way across. So folded flat palatoplasty is really good when you've got very, very thick soft palate. And there's a question how to avoid perforation during the procedure. You just don't want to go quite so deep, but if it happens, it's not catastrophic. And usually what I'll do is if I get a little perforation, I'll just close it up primarily. So I'll close that perforation and then go ahead and close the way we had intended to. I'm so sorry that this is blurry. It is a very difficult area to video. Okay, and so that's what it looks like when we're finished. So we've got a nice short and thin soft palate, and now I'm doing my laryngeal saccules. I'm just grabbing onto those with a DeBakey. I don't think that you're going to be able to see very clearly what I'm doing because I'm not looking down in the right direction, but let's see how well we can see that. So I'm just reaching in using Metzenbaum scissors, and I'm kind of teasing it out as I go. So I'm taking out that laryngeal saccule there. So just to explain a little bit more clearly what I'm doing there, when you look at the larynx from the front and you have the arytenoid cartilages here, and then you have the epiglottis coming down like this, and the laryngeal saccules are sticking out here. And so what we're going to do is we're going to grab on one of them here and retract it medially. So that's going to kind of exteriorize it, pull it out of the recess, and then we're going to cut that with some Metzenbaum scissors, and then we're going to do the same thing with the other side, pull it out like this, and then we're going to cut it with some Metzenbaum scissors. There's a question, any post-op edema at the site of surgery? So we don't have a big issue with edema, but we do ice these. What we do is we put gloved fingers full of water in the freezer, and then we freeze them. And then we just put the ice against the soft palate for about 10 minutes before surgery and about 10 minutes after surgery. If you cut too much, there is some potential, I guess, for oronasal reflux, although I've never really seen that happen before. I've heard of it if you take it all the way up to the front of the tonsillar crypt, maybe, but it's really not a big deal. Complications removing the saccule. The only complications that I can think of, number one, is if you remove the vocal fold, because let's say we're looking down quite deeply into the airway. This is the vocal cord or the vocal fold here, and the laryngeal saccule is sticking out from the vocal recess, which is kind of behind or in front of, sorry, the vocal fold. And so if when you're doing your cut, you inadvertently cut the vocal fold, you could run into problems with the bark. The other issue is that if you did it on both sides down here, you could potentially get webbing or granulation tissue formation down here, which would cause progressive airway obstruction down the road. The other thing that can happen is if you really shred that saccule when you're removing it, I have seen some dogs that deteriorate as a result of the surgery because you've created kind of this ball valve or this parachute that's filling the airway. And so you want to make sure that when you're removing it, that you remove the saccule in its entirety. Let's see what we've got here. And then I do extubate to do my saccules, and then you can see that I'm re-intubating here. And I'll just show you our little device that we use to hold the head. So this is, it's made for rodent dentals, and it's called an the company is called IM3, and it's just a dental holder, and they work so well. And I use these all the time for my my brachycephalic airway surgery. it's a partial saccule removal correct? No, it's not correct. You remove the entire saccule as long as you're leaving the vocal fold intact and not damaged at all. And that's absolutely critical, is to not damage that vocal fold at all. So again, this is the company that we get these from is called IM3, and it's a rodent dental brace. And if you tell them that I sent you, they'll know what you're talking about. All right, so let's just see if we've got anything else going on here. So then when I'm finished, I release that brace so that the mouth returns in its normal position, but you can see how you can adjust it up and down. Okay, any questions about that? All right, so let's move on to our next video. Let's see what we have here. I won't do Chiari. We can do a radius ulna fracture, because I know that fractures are very popular. So we can see our fracture here on the radiograph down at the bottom, and you can see the curvature or the bend in the leg. And so we're using a fixin plate, and the fixin plates are really, really nice. And I know I've always said this before. I always thought that they were a bit like our surgeons were being a bit precious when they were using fixin plates, because they're so much more expensive than regular plates, but they really are a lovely, very precise device. And so I'm actually kind of hooked. Once I started using them, I'm actually quite happy with them. So I'm peeling periosteum off down here, and then we are going to reduce the fracture using a couple of bone clamps. And at first I started looking at using a 2.7 dynamic compression plate, but that was a bit too big. And so then I've switched to this fixin plate. And I'm just going to move along a little bit further here. So that's my fixin plate in place. And the fixin plates are a locking plate. And there's a very specific way that you have to drill and place the screws and make sure that you have the little bushing in each of the plate holes. But they work really well. Good morning, Piyush. So, and I'm just checking to make sure that I've got bone underneath the plate all over the place. And then you put in your little drill guide. It pops or fits really nicely into that bushing, and then you just drill, and your screws engage into that bushing and the plate, and it becomes a locking style plate. So that's after the plate's been placed completely. Now, the other way that I like, especially if you don't have plating equipment, that I like doing radius ulna fractures in small or toy breed dogs is what I'll do is I'll hang the leg for the entire procedure. So I'll keep it hanging using stirrups or a towel clamp through the webbing. And then just the tension on that leg, it helps you reduce the fracture. So then I usually make a mini incision right over the fracture just so that I can realign it. And then I do a type 2 external fixator above and below the fracture, and then just use PMMA or methyl methacrylate as my connecting rods on the outside. And you want to make sure that either you have one threaded pin, top and bottom, or that your pins are not parallel. They go in like this. at least a couple of them are unparalleled, because otherwise the whole fixator can slide on the bone like this. Now, the advantage of using an external fixator is that you don't get the stress protection. Number one, the external fixator is going to have a little bit more micro motion at the fracture, which means that you're going to get more callus and it's going to heal more quickly. The other thing with an external fixator is that when you remove it, you haven't left any implants in place, which means that you're less likely to get the stress protection. Now, when you do remove this implant, you have to remember, when you remove this implant and your fracture is here and it's healed, you have to remember that you're going to leave little holes in the bone. And so they are points of weakness. And so what we usually do is splint the leg afterward for about 4 weeks after we remove that fixator. Okay, so type 2 external fixator is actually a great way to fix toy, small and toy breed dog radius ulnar fractures. Whoops. All right, so we'll go back to our video. And let's see what else we can talk about today. Let's talk briefly about toggle pinning. Oh, I think I already did this last time. Sorry, never mind. This is another brachycephalic. I'll just see if you can see a little better here what I'm doing. So again, I've got that stay suture in there, cutting with my blade, and I'm trying to cut really, really deeply down into the nasal cavity. I've got a request by Piyush to talk about a thoracotomy. Let's see if I've got one handy here. I'm just going to keep flipping through until... Actually, you know what? I'll do a whole thing on thoracotomy in the future. I won't do it right now. All right, so laryngeal tieback. So with laryngeal paralysis, we're looking at large and giant breed dogs. There's a question, how do you manage the safe corridors on the lateral side? I assume that you're talking about when the pin is passing through the tissues. And basically, I'm not too concerned about it. We're all tendon basically down there, so I'm not too concerned about the corridor that the pin is passing through. All right, so with laryngeal paralysis, let's just come over here. So when we're looking at the larynx from the side, or find kind of an oblique angle here, we have our epiglottis. You have our arytenoid cartilages here. You have the muscular process of the arytenoid cartilage here, and then you have the articular surface on the cricoid cartilage like this, and then you have the thyroid cartilage underneath. And the way that this works is that this is a synovial joint here, and the muscle that's missing is the cricoarytenoideus dorsalis, and that goes between the muscular process of the arytenoid cartilage back to the back of the cricoid cartilage. And so it pulls up in this direction and pulls. So if you look here, you have the arytenoid cartilage is here. You have the epiglottis that covers the airway like this. And then you have the cricoarytenoideus dorsalis muscle here, which is pulling that airway open. And that's how it works. And then the recurrent laryngeal nerve is what innervates that structure. And so when you have laryngeal paralysis, what happens is that instead of having opening of the airway on inspiration, you have suction and negative pressure on the inside of the airway, which pulls the arytenoid cartilages back together. So you're getting kind of the and that's what happens with laryngeal paralysis. And so what we want to do with a tie back is that we want to pull it open far enough that we're going to improve our breathing, but we don't want to pull it open so far that you're going to leave a gap between the epiglottis when they swallow food, and you don't want them to aspirate. So that's the big complication that we see with laryngeal tieback surgery is aspiration pneumonia, and it occurs in around 10% of cases acutely and up to 30% chronically. So what I'm going to do when I'm making my approach is I have my jugular vein here, and then I have my maxillary and linguofacial here, and then I'm going to palpate the dorsal aspect of my thyroid cartilage there, and I'm going to reflect that down, and I'm going to make my incision right over, just underneath the jugular vein and linguofacial vein, over the thyroid cartilage, and then I'm going to reflect that thyroid cartilage ventrally. And then once we do that, I'll be able to palpate. I'm going to be able to palpate the muscular process, which is sitting right here. And then I'll be able to develop that articulation between the cricoid and arytenoid cartilages. And then we're going to pass a suture around the back of the cricoid. And it's going to come up out of the cartilage here. And then it's going to pass through the muscular process here and up like this. Now you have to remember that the articular surface of the muscular process is shaped like a pear. You want to make sure that you place your suture bites ventrally, not dorsally, so that there's more cartilage for it to go through, so it's less likely to fracture. You've been missing all of that, sorry. And so I apologize for that. So just to review that, the muscular process, the articular surface looks like a pear, and so you want to make sure that you're placing your suture bites down here ventrally and not dorsally. All right, so we'll go back into the video here. So I've drawn a line that's over my thyroid cartilage, and then my jugular vein is going to be just dorsal to that, or just above that on your image. And so I make my incision right over the dorsal surface of the thyroid cartilage. And then you can see the platysma muscle or at that level. And then I'm going to incise the platysma muscle. And you want to make absolutely sure that we're being very, very careful with hemostasis, because you don't want a hematoma to form, because that can contribute to respiratory distress after the procedure. All right, so now I'm cutting through the platysma muscle, and then I'm going back and palpating the thyroid cartilage, and I'm incising that subcutaneous tissue. That's my maxillary vein right there, so I'm going to have to reflect that dorsally. And this is a procedure that you definitely want to practice on a cadaver several times before you try it in a clinical patient. So now I'm going back and palpating my thyroid cartilage. This is the left laryngeal tieback. And then I'm taking my finger and passing it over. So you can see I've reflected the linguofacial vein dorsally. And then the next thing I'm going to see is my thyropharyngeus muscle. And you can either split the thyropharyngeus muscle vertically or horizontally. I used to do it horizontally, but now I do it vertically so that we get less effect on the swallowing reflex after surgery. So I'm just right at that's the thyropharyngeus muscle there that I'm pointing out. And I'm making a vertical cut in the thyropharyngeus muscle. And you should be able to see the white of the thyroid cartilage deep in there. I have a preference. I always do left because when you're passing your suture with your right hand, it's easier to go from right to left. The only time I do a right-sided one is if I fracture through the muscular process. On my left side, I'll switch over and do my right one. So I've made my vertical cut in the thyropharyngeus muscle. And then I get my Gelpi retractors in there, and now I'm looking down at the muscular process. So that's the thyroid cartilage there, just reflecting that out of the way. And it is very easy to get lost here. So you want to be really comfortable with your anatomy. Now I'm just retracting thyropharyngeus out of the way, and there's this weird connective tissue that you can feel. If you go too far cranial, you're going to pop into the oral cavity, so just in front of the larynx. And I'm just kind of bluntly dissecting through this connective tissue. And that purple muscle that you see there is the cricoretinoideus dorsalis muscle. Right in there. So that's cricoretinoideus dorsalis. And it's always bilateral. So laryngeal paralysis in dogs is always bilateral, and we're always going to do just a unilateral tie back. And I always do the left side. So that white that you can see in the center of the screen is the muscular process, and then the purple is the cricoretinoideus dorsalis that's heading up and away from that. So I'm palpating that muscular process, and then I'm going to get a right angle forcep and put it underneath the cricoretinoideus dorsalis muscle. So I'm just going to take a break here for a second. We'll come down. Now what we're looking at is we've got the muscular process sitting right here. And then we have cricoretinoideus dorsalis muscle heading up in this direction like this. And I'm going to pass a right angle forcep underneath the cricoretinoideus dorsalis, and I'm going to cut it with my electrocautery. And so then what we're going to see is the cricoretinoideus dorsalis muscle in cross-section, and then this is the other end of it over here. And then deep in here, we're going to see the articular surface of the cricoarytenoid joint. Whoops. So I'm passing underneath the cricoretinoideus dorsalis muscle with my right angle forcep. And then I'll cut that with my electrocautery. So this is the cautery here that I'm cutting through. Sorry, I've lost the other video. My GoPro died. All right, so now I've transected the cricoretinoideus dorsalis muscle, and then I'm going to use a freer elevator to establish that articulation between the cricoid and arytenoid cartilages. And you can get this frustrating oozing here, and you have to make sure that you address that, because if you don't, you're going to have a hematoma form after the surgery, and they're going to struggle to breathe afterward. So now I'm using a freer elevator. So that's the cricoid cartilage, the white that you can see there. And I'm pulling the muscular process of that arytenoid cranially. Then I'm going to stick, sorry that my headlamp is in the way. I'm going to stick a freer elevator in there. And now you can see that articular surface right down there. So you can actually look down. My head's exactly in the wrong way, but you can look down into that joint down there. Okay, can you guys see that articulation? All right, and then we'll start passing our sutures. So I'm going to put a right angle around the back of the cricoid cartilage and reflect that kind of laterally. And then I'm going to take 2 strands of 2O proline. So it has to be a non-absorbable suture. It's going to have to be there forever. And we'll pass it around the back of the cricoid cartilage. So let's take a break here. So let's say this is our cricoid cartilage here. Whoops. So this is our cricoid cartilage here. And then I'm going to pass my suture around the back of the cricoid. It's going to exit kind of right here. And then I'm going to take that suture and pass it through the muscular process and then out like this. So I'll redraw that because that's a terrible drawing now. Okay, so looking from the side, we have our cricoid cartilage here. The articular surface is right here. The muscular process is right here. The cricoretinoideus dorsalis muscle used to be right here. We're going to take our suture and pass it around the back of the cricoid. And then it's going to exit right about there. And then we're going to pass it through the muscular process here ventrally. And it's going to come out like this, and then we're going to tie it. You want to make sure you don't pull it too tight, because if you do, you're going to pull the airway open too far. And you're going to have a higher risk of aspiration pneumonia. So I'm passing my suture. This is my second suture. It's going around the back of the cricoid cartilage. And you'll see the needle appear kind of in the middle of the lateral aspect of the cricoid cartilage. And I take my right angle out and I pass the needle again through the ventral aspect of the muscular process. And it should pass through easily. I'm using a taper needle, by the way. So definitely a taper needle. You don't want a cutting needle because that will fracture the muscular process. You can see that I'm jiggling the muscular process with my suture, if you could see around my head. So now I'm going to tie that, and I'm not going to tie it terribly tightly, because if you tie it too tightly, you're going to lateralize it too much and increase your risk of aspiration pneumonia. So I just want it to barely tighten up, because I'm using a fairly large endotracheal tube. So the cartilage is already being pushed out just with the presence of the endotracheal tube. So basically my suture is just going to kind of hold things still, maybe pull it open just a little bit further. And again, make sure that you do this in several cadavers before you do it on a clinical patient. And then once I'm finished tying these sutures, then I'm going to look in orally to make sure it's not pulled open too far. And if it is, I'm going to cut my sutures and replace them with looser ones. Okay, is that pretty clear what we've done there? Then we want to make sure that all the bleeding is absolutely stopped. And then we take out our retractors. So that's the thyroid cartilage right there that you can see. We take out our retractors and look in orally to make sure that we haven't pulled it back too far. And then we close that vertical cut in the thyropharyngeus muscle. And then we just close subq and intradermal. All right, any questions about laryngeal tieback surgery? If you decide that you're going to try one of these, you can send me a message on VetDojo on YouTube, or email me or whatever, and we can discuss it further. Also, if you try a cadaver and you want me to comment on how your video on how your dissection went, you can send me a video and I'll let you know, or send me photos or whatever, and I'll let you know what I think of how you've done. All right, any questions about this or anything else related to surgery or philosophy or life in general, my kids, what my favorite music is? So there's a comment that may cause a lot of edema. Any trick to avoid that? The big thing is just to be really careful with your dissection. So use very gentle technique. Don't overuse cautery, but you want to make sure that the bleeding has completely been addressed before you close it up. Any other questions or comments about anything? So again, if you haven't already done so, please consider joining our YouTube membership. So there's a question here. Can I discuss anal sacculectomy? So I don't do a lot of normal dog anal sacs. I only do anal sacculectomies for anal sac adenocarcinoma. You guys probably have more experience with routine anal sacculectomies than I do. But when I do them for anal sac adenocarcinomas, we never have an issue with incontinence. The issue that you're going to have is when you're doing bilateral anal sacculectomies, and you damage both caudal rectal nerves. I've never done it before, but I certainly have heard about it happening. But maybe I'll pick that up on another video. Another comment here: do I open the joint? So I assume that you're talking about with the laryngeal tieback. I do open the joint because I like to see that articulation, and it helps me place my needle better in that ventral aspect of the pear-shaped articular surface. How long did I spend in Australia before I picked up the pronunciation of trachea instead of trachea? Probably about a year, when people were making fun of me, and my children continue to make fun of me for my American accent. Colic anastomosis in cats. I can definitely talk to you about subtotal colectomies. We're out of time now, but I can do a video review of the subtotal colectomy in the future. Any questions or comments about anything else? I hope you enjoyed the video. If you haven't already done so, please subscribe to our channel and like this video. And question about antibiotic I use. So intraoperatively, I always use cefazolin, just intravenously every 90 minutes. And I don't typically use postoperative antibiotics for anything unless I've got obvious infection going on there. There's a comment about language barriers. Don't worry about that at all. And I'm just grateful that you're watching and giving it a go. And if you need me to repeat something, certainly just let me know, and I'll slow down and I'll repeat it. And then postoperative pain management for laryngeal tiebacks. I assume that these aren't terribly painful. I don't like to use full agonist opioids. I just use buprenorphine on these and maybe a touch of ACE. And so I don't use full agonist opiates. I don't think that they're terribly painful, and so I'd rather avoid that respiratory depression. Comment about antibiotic selection for colon surgery. Again, I'm just going to use cefazolin during the surgery, and then I'm just going to flush it out, and I'm not going to continue antibiotics postoperatively. Any other questions or comments? We have about 2 minutes left, but I'll stick around and wait. And I'm very grateful for you guys watching, and J10, you're very welcome. Yeah, I hope to see you again soon in a couple of weeks. We may have some variability in when we can offer these over the holidays, because I'm going to be away for some of the time and James is away for some of the time, but we're trying to make sure that we have good coverage. Post-op pain management for cat GIT surgery, usually methadone while they're in surgery, and then home on buprenorphine orally. I don't have the doses, I'm sorry, but that's typically what we do. Any other questions or comments about anything? I really enjoy doing these, and I love seeing the same familiar names and sometimes the faces on the Zoom rounds, and I love the banter that we have back and forth. And I'm very happy for you guys to tease me and give me a hard time. I think it makes it really fun. I'd rather you tease the person that's scrubbed in to surgery with me than me, but if you have to tease me, then I can certainly take it. All right, guys, I'm going to go ahead and wrap it up, and we will see you again soon. I'm not coming to the US for Christmas. I may be coming in February, but I'm not sure where I might be in Phoenix, and I might be going to South Carolina, but we will see. So thanks again, guys, and we'll see you soon.